let's talk about aminophylline for just a few minutes. This is a drug we don't see quite as often as we used to, but we do still see it in stable patients with stable COPD. Caffeine is a xanthine. Aminophylline, theophylline, and caffeine are the methylxanthines. They stimulate the central nervous system and they stimulate respiration. They dilate the coronary and the pulmonary vessels, so they improve the circulation. And they cause diuresis. So if you have a patient who's on theophylline, they may be at risk for losing what? Fluid volume deficit, right? Theophylline is a medication we've been using for a long, long time. It relaxes the smooth muscles of the bronchi and the bronchioles, and it relaxes the smooth muscles of the pulmonary blood vessels. And it does this by inhibiting an enzyme, phosphodiesterase. So what does phosphodiesterase do?
Increases CAMP.
It increases CAMP. What is CAMP? And what's it for? In the cell?
Kind of energy.
Energy, right. And so if it's broken down, okay, by phosphodiesterase, then it's not broken down, right? If you are inhibiting the release of this enzyme that breaks down cyclic CAMP, then you're allowing more of it to be circulating. Okay? Does that make sense? You guys understand that? If you have an if you have an enzyme that breaks down something that increases energy production, normally you break it down. You don't need so much of it, but you want to keep it in the system. You want to keep it going because you have to be able to continue to run from the tiger. You don't want that enzyme breaking things up and putting them back into circulation. You want to decrease that enzyme, and you decrease the production of that enzyme. Then you allow the sympathetic nervous system to keep on going. Does that make sense? And that's why we care, basically. Now, theophylline has what we call a low therapeutic index. Who remembers what therapeutic index is? The range when it's helpful and not harmful. So what do we mean by low therapeutic index? Can be dangerous. Exactly, Mary. Exactly. Can be very dangerous. So what do you think we do to monitor theophylline when we give it to someone? Well, we draw theophylline levels, okay? And how often we draw them depends upon what's going on with our patient. We use it most of the time. Did I skip something? No, I'm just looking at. I'm sorry, guys. I'm missing everything that came before theophylline. Oh yeah, well maybe I just start with bronchodilators. Okay, sorry about that. It's the afternoon. We'll get to it. I just looked at this and realized I'm missing about 8 pages of this PowerPoint. And it could be at home, because I did this late last night. So we'll just, sorry, I backtracked. Edit. So it has a low therapeutic index. That means it's got a very narrow range. And it has very serious adverse effects. And it interacts with lots of drugs. So we don't use it like we used to use it. It's not any more efficacious than beta agonists, which we would have talked about earlier, but we didn't, or glucocorticoids. We use it most of the time we have somebody who's stable. We don't use it very much anymore. Because it's contraindicated with seizure disorders, with cardiac disorders, with liver disorders, with renal disorders. And most of our hospitalized patients have got one or more of the above. And basically what it does, it results in dilation by increasing CAMP. Because it stops the enzyme that breaks down CAMP. So, what are some of the side effects? Is it up there? Not yet? Theophylline has lots of, what happens when somebody gets the caffeine, drinks too much coffee? Gets caffeine jitters. They do, they get the jitters, okay? Theophylline causes anorexia, causes nausea, causes vomiting, causes gastric pain, causes intestinal bleeding. This is all in your PowerPoint. Makes people nervous, makes them jittery, makes them anxious, takes away their appetite, gives them headaches, okay? Gives them palpitations, can cause hypotension. It's just not a very pleasant drug. So we don't use it very much because we've got other better drugs now. Yes.
Does it cause hypotension because it also dilates your
Over time, coronary arteries too, yes. It interacts with other medications. It interacts with DIG, digitalis. It can cause DIG toxicity. If you have a client who's on lithium, it decreases the effects of lithium. If you have a patient with seizures, and they're on phenytoin for seizures, then that can decrease your theophylline level. So there's a lot of drug interactions. We really don't like this drug. We don't use it like we used to. Another form of the sympathomimetics are the alpha and the beta-2 adrenergic agonists. Okay, we talked about theophylline first, one we don't use much, but one you will see and you need to be familiar with because it's such a dangerous drug. The alpha and beta-2 adrenergic agonists, what do we mean by that? Anybody know what's an agonist? Makes it work better. Don't think agony. Okay? An agonist helps something work. So if we have something that's a sympathomimetic alpha beta-2 adrenergic agonist, thinking about naming drugs, what do we know just from those names? Sympathomimetic, and what are the two primary transmitters? Epinephrine and norepinephrine, fight or flight, okay? Adrenergic, adrenal. What do the adrenal glands produce?
Epinephrine or no?
And do they produce cortisol too? What does cortisol do? Reduces inflammation, but it also raises your blood sugar, right? So let's think about what these drugs can potentially do already. They mimic the sympathetic nervous system. They're adrenergic agonists, which means they're similar to, they help out, they work with adrenergic hormones. Adrenal, I'm sorry. I can always tell when it's the afternoon because about 2 o'clock my brain goes. Adrenaline, yes. Epinephrine drugs. Okay? Thank you, Jamie. It's like, you can always say every now and then Jamie goes, oh, that's the word you're looking for. Thank you. Oh, was it? Was it? Angela back there. Okay, dokie. So, we like these drugs, okay? The only one that we will use in true emergency, if we have someone who is having a respiratory arrest, we're going to use epinephrine, right? Because immediately, what's it going to do? It's going to dilate the bronchioles, all right? And we're going to not have a respiratory arrest. So that's a very important emergency drug for you all to know. All right, epinephrine. We give epinephrine if someone's getting ready to have a respiratory arrest from any sort of anaphylactic anything. It immediately dilates the bronchioles. Yes, Melissa? Yes, that's the whole EpiPen. That's EpiPen. Sympathomimetic, okay? The first drug that we developed to work on asthma and chronic obstructive pulmonary disease was Isuprel, okay? Actually, Isuprel came along before albuterol and the Albupen. It doesn't have any alpha properties. It's a non-selective beta agonist, okay? Later on, as you get into more med-surg content, you'll be talking about alpha and beta receptors. Alpha and beta receptors stimulate or suppress different things. What you need to know right now is that Isuprel is a non-selective beta agonist. That means any beta receptor would go after it. But it is the first beta adrenergic medication that was used for bronchospasms, and it's very effective.